The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome to this first program in the TV series MS from A to Z. My name is Dr. George Kraft, and I am the Alvord Professor of Multiple Sclerosis Research, Professor of Rehabilitation Medicine, and Adjunct Professor of Neurology at the University of Washington in Seattle. I am also the Director of the Western MS Center, which is the clinical center at the university, and the principal investigator in the Multiple Sclerosis Rehabilitation Research and Training Center, a national center funded by the National Institute on Disability and Rehabilitation Research. It is my pleasure to welcome you to the first of this TV series. I will be the host of all of the following programs of this one-of-a-kind endeavor. This is going to be a comprehensive year-long series of educational programs planned to provide you with the important information about MS you need to manage your life. The speakers in this program are prominent MS clinicians and researchers from the United States and Canada. You will be familiar with some of their names. This TV series will give you the opportunity to electronically meet them as well as learn from them. Please consult the website shown on this screen for the information about where and when you can view this series. This is the opening program. In it, I want to do two things. First, I will review the subsequent program topics and give you some information about each of the speakers. Second, I will give you an overview of MS and review the current thinking about what MS is. I hope that giving you this background will make the subsequent programs more meaningful. Program 2 in this series will be presented by the distinguished MS researcher and clinician, Dr. Jock Murray. Dr. Murray is acknowledged as the world's leading expert on the history of MS. He comes to us from Halifax, Nova Scotia in Canada, where he has served as Dean of the Dalhousie Medical School, Chairman of the Department of Neurology, and founder and director of the MS Clinic. In the history of the world, MS is a relatively new disease. Since its first complete description in the mid-1880s, much has been learned about this disease, and the pace of new knowledge is truly remarkable. I'm sure you will enjoy Dr. Murray's presentation. The third program in this series will be somewhat different. It will not be a studio presentation, but a live meeting with an audience organized by the Greater Northwest chapter of the National MS Society. The program will deal with the important topic of jobs for persons with MS, along with other vocational issues. This meeting will feature Travis Gleason from the National MS Society, Dr. Kurt Johnson from our Multiple Sclerosis Rehabilitation Research and Training Center, Ray Hecox, President and General Manager of King 5 and Kong TV stations in Seattle, and Andrea Brennicke, an attorney with McDonald, Hogue, and Bayless in Seattle. Program number 4 will feature one of the leading researchers from our MS Research and Training Center, Dr. Charles Bombardier. He is a psychologist who is an expert on depression in MS. He will discuss the prevalence of depression in MS and ways in which it can be evaluated and managed. In addition, Dr. Bombardier will review the role of exercise in MS. Dr. Bombardier has recently received awards from several national organizations and been interviewed by news organizations for his research in this area. I know that you will learn a great deal about this important and common problem from his presentation. The fifth presentation in this series will be made by Dr. John Kurtzky. Nationally and internationally, His is the most recognized name in the MS field. Everyone who has MS is rated for their level of disability by a scale developed by Dr. Kurtzky, called the Kurtzky Scale, or the EDSS, which stands for Expanded Disability Status Scale. The Kurtzky Scale is the standard measure of the effectiveness of MS medications in clinical trials throughout the world. Dr. Kurtzky is also acknowledged as a leading researcher of the epidemiology of MS. In this 5th program, he will present his research showing the manner of transmission of the disease and give clues to its cause. For his many major research achievements, Dr. Kurtzky has been awarded the highest honor of the National MS Society. Dr. Kurtzky will come to us from Washington, D.C. for this presentation. The 6th presentation will also be by another member of the MS Research and Training Center, Dr. Don Eady. Dr. Eady is also the director of the Research Training Fellowship Program at the University of Washington, which is sponsored by the National MS Society. She is an expert on the common but very complex problem of pain in MS, and her research has focused on innovative methods to manage it. She will talk on pain and the most common MS symptom, fatigue, which was first reported by researchers at the University of Washington. The 7th program will be a team effort by clinicians from the Western MS Center. Doctors Mary Pepping and Mo Goldberg, both psychologists at the center, will discuss the assessment of cognitive problems brought on by MS and ways to manage them. Dr. Pepping is an excellent speaker and has participated in writing the National MS Society's policy paper on cognitive impairment in MS. For the 8th presentation, we will again have an outside speaker, Dr. Alan Bowling. Dr. Bowling is from Denver and is internationally acknowledged as the leading medical expert on the use of complementary and alternative medicine for persons with MS. He has a popular book and a widely used website on this topic. Many people with MS are very interested in the use of vitamins, herbs, marijuana, and other non-standard treatments for this disease. For this reason, I am sure that you will be fascinated by what you can learn from Dr. Bowling's presentation. For the 9th and final program, we are very pleased to have Dr. John Rickert, Executive Vice President of Research and Clinical Programs for the National MS Society in New York. He will share with us highlights in MS research in 2010. I anticipate many major new developments in the field of MS over the course of this year, and there is no better person to present these findings than Dr. Rickert, whose hand is on the pulse of worldwide medical research. And because he represents the National MS Society, we can be assured that his presentation will be completely impartial. We are very pleased to have him as part of the program. While he is here, he will also review the importance of the role of nonprofit agencies in healthcare research and management. Well, this is our lineup for this TV series. All of the topics chosen are very important for persons with MS, their families, their colleagues, and the general public. However, these topics are often overlooked in presentations made to patients. I believe that this series of 9 varied television programs is probably the most ambitious effort of this type that has ever been made. And you don't have to go to it, it comes to you nationwide on a regular monthly basis by means of the UW television network and the Research Channel. Because it comes to you, even those of you who are homebound will be able to benefit from this series. Once again, the website on the screen provides information as to where in your region of the country you can find this 9-part series. For those of you who cannot receive it on their TV or who want to view the program at another time, these presentations will also be available as webcasts and podcasts through the website. In this remaining part of this program, I will give you an overview of MS. I've divided this into 9 parts. The first part is to answer the question, what is MS? In the second part, I will talk about what causes MS. The third part, we'll talk about the pathology. The fourth part, about the course of the disease. The next part, about the symptoms of the disease. Next is the treatment of the disease. Following that is a concept called the paradigm shift of a new way of looking at the disease. Next will be symptom management, and finally, some words on clinical trials and further information. If I would ask any patient or anybody who knows a patient with MS what this disease is, I think you would all say it is a demyelinating disease. But what does that mean? What does it mean to be a demyelinating disease? Myelin is a fatty material that coats each of the nerve fibers in the body. The myelin on the nerve fibers is very much like insulation on a wire. When you turn on a light in your house, the power gets to the light bulb through a wire. If you didn't have insulation on the wire would not conduct electricity very well. It would probably short out, and things would not be working properly. And that is really the fundamental view of what MS is. It alters the insulation on the wire. Now, I'm going to tell you about many more things that MS does, but that's the starting point. It is a demyelinating disease which affects the conduction in the wire. But the wire is also important. And without the wire, there would be no conduction at all. So it isn't just as simple to say, well, MS is a demyelinating disease. MS also affects the wire. It also affects the nerve fiber itself, which we call the axon. In fact, when MS occurs in flares where there are exacerbations, in which a patient may have a sudden onset of symptoms which may last 1 or 2 weeks and then get better, those symptoms are caused by some damage to that insulation. But the fact that the symptoms get better are an indication that the wire itself has not been damaged. Unfortunately, in some types of MS and in some patients, and in most patients over time, the wire does take a toll. Think of going out in the really, really cold weather without your overcoat, which is like insulation. The patient who's going out without an overcoat might have a lot of symptoms and actually might have some very severe problems from simply freezing. And that can happen to the wire. The wire can be so severely affected that it's damaged forever and actually dies out. That is the more or less simple starting point of understanding MS, a disease of the insulation of the axon and a disease also of the axon. We now know that there is not just one type of MS, there are 4 types of MS. One type of MS, so-called type 1, is produced by immune cells called T cells, which cause much of the damage in MS, getting into the central nervous system and causing some inflammation of the myelin, of the coating of the axon. The second type of MS, type 2, involves the T cells, which get into the central nervous system and cause damage to the myelin, the coating of the nerve, but also there are circulating antibodies, a different type of antibody protection going through the body that are associated also with damaging the nervous system. The third type and the fourth type of MS are really not diseases of the myelin or not diseases of the axon, but they're diseases of the cells that make the myelin, the so-called oligodendrocytes, which literally spin the myelin around the axon. These are probably the less common types of MS, and it's likely that any of our medications that we use to treat the disease probably would not improve somebody who has this type of MS. So The important point here is to understand that MS can look like MS can look like MS. Different MS can look like different MS, but there may be an underlying different pathology in each case. For many years, we've known that there were two interesting findings associated with the development of MS. The first was a geographic component, and the second was a genetic component. In the geographic component, it was clear that persons who got MS tended to frequently be born in the northern part of the United States or the northern part of Europe. People who were born in the tropics or in the warmer areas of North America were less likely to get MS. The second thing was the genetic pattern. It appeared that people whose ancestors came from Scandinavia or Northern Europe were more likely to get MS than persons whose ancestors came from the tropics or from Southern Europe or from Africa. So the mixture of genetics and where a person was born seemed to be very important in the development of this disease. Now that we know that there is a geographic factor and a genetic factor in the probability of developing the disease of multiple sclerosis, what is their interaction? So I'd like to answer that question by asking you to think about the fact that all of us, no matter where we are in the midst of hundreds or thousands of viruses and bacteria floating around in the air. We touch things that are contaminated, we breathe air that's contaminated, but we are all protected by our immune system so as to not get sick. So the immune system, even though MS is considered an immune-mediated disease, the immune system is our friend and not our enemy. However, in certain persons, under certain circumstances, the immune system goes wrong and produces MS. So let me give you an example of how this might happen. If a baby is born into the world and has no immune protection, it's likely that that baby would not last more than a few minutes because of the bacteria and viruses in the air. However, the baby generally does very well. So where did the baby get the immune protection? Well, the baby got the immune protection from her mother. The immune protection of the mother was built in the mother's body over a period of development by encountering these various bugs in the atmosphere and building immune protection against them. So the baby who is born comes into life with the same protection that the mother has developed over her lifespan. Now that holds for weeks and months, but while the baby is now being protected by the mother's immune system, the baby is also acquiring new protection of new bugs in the air by the immune system. The immune system has the ability to see an invader, so-called antigen, and build antibodies to that antigen. And therein lies one of the secrets of what causes MS. It appears that people with certain tissue types, certain genetic backgrounds, have different abilities to form antibodies to various antigens in their vicinity. And it appears that people who grow up in the northern part of the northern hemisphere, where there is less sunlight and where there is more cold, people are indoors more of the time, these are the people who tend to develop MS. So the typical person with MS is somebody whose ancestors came from Northern Europe or Scandinavia, grew up in the northern part of the United States or Europe, and then develop the disease maybe 10 or 20 or 25 years later. The immune system produces attacks on the body's myelin that are generated by seeing a similar or related antigenic stimulus in the atmosphere. And in these people, the immune system seems to get mixed up and not only attacks the invading virus, but also attacks certain parts of the myelin. We call this mistargeting molecular mimicry, and over time, when repeated bouts of this occur, there can be a spread of this damage, which we call epitope spreading. This is a summary of the current thoughts on the mechanism of multiple sclerosis. I mentioned at the beginning that MS is not just one disease, that there are at least 4 pathologic types of MS, and different immune components play a role in each one. The pathology of MS is also not just one type of pathology. Typically, there is the attack on the myelin by the immune system. This generally results in what happens when any attack occurs on any body tissue. There's inflammation. When there's inflammation, there is swelling and fluid and compression of tissue function, and the tissue does not function normally under those circumstances. If that inflammation continues or gets worse, it can actually cause the loss of myelin, severe damage to the myelin in that area. And if that continues, it can go on to damage the wire or the axon itself. From the standpoint of clinical types, we, in the care of patients with MS, like to differentiate the patient as to what type they have. 85% of persons with MS have what we call relapsing remitting MS or secondary progressive MS. When you think of MS, it's the relapsing remitting MS that you're probably thinking of. This is a pattern where the disease causes some symptoms in some part of the body, which then maybe will stay there for 2 weeks or so and then get better. This is the so-called exacerbation or the attack. Getting better is called the remission. So relapsing remitting MS is one characterized by this clinical pattern. But it appears that this clinical pattern can be seen in any of the 4 pathologic types as well, so it does get a bit complicated. The relapsing remitting type of pattern occurs for 10, 15, 20, 25 years in patients with MS, and over time, because of the accumulation of damage, it can evolve into more of a progressive form with much less pronounced relapses. So the secondary relapsing form can evolve from the relapsing remitting form. The 15% or so remaining patients have more of a progressive course, and this is known as primary progressive MS or progressive relapsing MS. These patients appear to be quite different. They generally are older when the disease starts. They're more likely to be males than the relapsing remitting type. They do not get better, they simply progress. And perhaps the most important fact is that the various disease-modifying treatments that we have do not work in this category of patients. So the gender of the typical relapsing remitting patient is increasingly female. We now have evidence that it's 4-to-1 females over males, whereas with primary progressive or other progressive form called the progressive relapsing form, it's equal male to female. Also, it's important to remember that MS is a disease of the central nervous system. So MS can occur in the brain or in the spinal cord. Many times a person's major symptoms may not come from brain lesions, but from lesions in the spinal cord. This is recently being recognized as being a very important point in understanding the disease and knowing how to manage it in different patients. In this fourth component of the overview, I want to talk about something that really is one of the most important aspects of understanding this disease. And this is all information that is relatively new over the past decade or decade and a half. It used to be thought that when someone with MS who had relapsing remitting MS had one relapse every year, that they were doing very well. But that was before the age of MRI. MRI has allowed us to look into the brain and the spinal cord and identify when the disease became active. And a very perplexing thing was noted, and that was that patients seem to have many more episodes of new lesions occurring in the brain and spinal cord than the patient was aware of. And this seems counterintuitive, doesn't it? That you would think that a person would know when they're having a flare or activity of their disease, but they don't. And with new MRI machines, which are now up to so-called 3 Tesla or 3T strength, we're seeing more and more activity that patients are seemingly unaware of. Now, why is this? I'd like you to think in terms of your dog or your cat, or think of a pet you've seen. And you know, when we talk about exacerbations, we think in terms of some temporary blindness in an eye, or some weakness of a foot or ankle, or some numbness in a hand. We generally think in terms of visual strength or sensory symptoms. And yet, if you look at your dog has probably better sense of vision and smell than you do, probably better strength in the limbs than you have, and yet has only maybe 20% the size of a human's brain. So it has become clear over the past decade and a half that what happens is in MS patients, they can have a flare or an exacerbation in some region of the brain that does not go to the eye, does not go to the arm, does not go to the legs, but actually goes into that part of the brain that does thinking, the part of the brain used for memory, the part of the brain used for emotional control, and the part of the brain used for integrative or multitasking activities. So this has really changed the way we look at this disease, and I think has given us a lot of insights on better ways to manage it than we've had in the past. Now, over time, there will be attempts at remyelination where there are areas of demyelination, as I mentioned. On the other hand, as I also mentioned earlier, ultimately the wire, the axon, will get damaged and simply not function. And over the period of many years or decades, this disease takes its toll on the human brain. And yet people who have had MS for a long period of time and who have a lot of residual damage in the nervous system can still function at a very, very high level. What happens, and how does that mechanism of keeping function at a high level work? It's probably through something we call neuroplasticity, which means that when an area of the brain is damaged, information that usually is processed in that area of the brain will be transported to a different part of the brain and processed there. This is what we call plasticity, neuroplasticity. Studies have shown that even early in the disease, a person who has to activate some motor activity or some cognitive problems will bring into play lots of parts of the brain that were not normally used for this before they had MS. This means that parts of the brain are doing double duty or triple duty. They're trying to perform activity to keep the person functioning well and yet maintain their own type of area of function. This can cause then some of the earliest symptoms of MS, and that is the difficulty in multitasking. I believe that this concept of neuroplasticity and neural repair is really what lies in the future for us in better managing patients with MS. I should mention right now that one of the best things you can do to help your neuroplasticity is to get good rest, good sleep. It appears that the most efficient time neuroplasticity occurs is during deep sleep, we call this slow wave deep sleep. Because it is a disease of the brain and the spinal cord, it is not surprising to think that in a random acquisition of lesions throughout the brain, brainstem, and spinal cord, it would be likely that at the end of that series of neural connections, which would be the legs and feet and bladder, you'd expect that that might be the area that has received the hardest hit. And I think that's what we all see when we look around and see persons with MS. It's fairly common that patients with MS will have problems in those neurologic functions that require the longest neural pathway to function properly. These would be the feet and the bladder. The other area that frequently is affected is the optic pathway. And for reasons that are not entirely clear, the optic pathway is also a predilection for the site of MS lesions. Problems that can occur involve weakness. That makes sense if you affect the nervous system that goes to muscles. Sensory deficit or sensory abnormalities, and abnormalities in sensation can be perceived as pain, and that makes sense since we're talking about a disease of the nervous system. Spasticity, which is the inability for muscles to fully relax, and the fact that muscles will tense up inappropriately at times, causing spasms. These can be a problem in MS because the balance in the spinal cord, in the brain, between all the areas of the neural system that have to work together for smooth performance can be interfered with by MS. So spasticity is a problem. Tremor can be a problem, again, related to damage in the brain that causes smooth movements. If that's damaged, there will be some shaking or some tremor. I mentioned in the last portion of this overview that MS can affect many parts of the brain and the spinal cord. And I also mentioned that it does not just affect the parts of the muscles that cause contraction or skin sensation, but can affect parts of the brain that are used for cognitive processing or emotional control. And I also mentioned that as the disease progresses and as damage accumulates in the nervous system, the neuroplasticity takes over and moves information around in the brain and spinal cord, so that at certain points in time, you will find that a patient with MS is doing the same activities, but doing them with different parts of the nervous system. This is the neuroplasticity we'd mentioned, which is so important. I believe that it's, in part at least, this neuroplasticity, which means that people with MS are working harder to do the things that for those of us who don't have MS is much easier to do. I believe that in part, at least, this is responsible for the fatigue that persons with MS complain of. As I had mentioned in the introduction of this series, fatigue was first identified as a problem in MS by researchers at this institution, and we still find throughout all sorts of surveys that everybody does, we find that it's still the most common symptom of MS. It seems to me that if the brain has to do more work because more parts of the brain are functioning to do more simple things, that fatigue is simply an end product of this altered functional behavior. We are fortunate that we now have a number of good medications to treat this disease. This was not true before the latter part of 1993, when the first disease-modifying treatment got approved and available in North America. I want to give you the history of treatment of MS to sort of help you understand how this disease has been approached by physicians over the past many decades. As I mentioned, the first full, accurate, good description of MS was in the mid-1800s. Many opinions were voiced as to what caused the disease, but by the second half of the 20th century, there was a increasing agreement that this was an immune-mediated disease, that the immune system somehow was attacking the nervous system. And we've talked earlier briefly about how the genetic makeup of the person and the region in which they were born seemed to be associated with the probability of getting multiple sclerosis. So for many decades, science has known that the immune system is a major factor in causing this disease. So the first medications that were used were those medications that would suppress the immune system. These were drugs that were used for cancer, so-called cytotoxic medications, and immunosuppressive medications that decreased the activity of the immune system, that suppressed the immune activity. These immunosuppressive medicines did help MS. However, they tended to be very toxic because when they suppressed the immune system, they suppressed all aspects of the immune system, even though only certain parts of the immune system were attacking the myelin in the brain and spinal cord. And it was apparent that higher doses of these cytotoxic medications actually suppressed MS activity better. And to use more potent immunosuppressive cytotoxic drugs, the patient was helped even more, but toxicity was greater. The higher the dose, the better the MS was treated, but the more side effects the patient had. And we've also talked about the importance of the immune system to protect the human being. That's what the immune system is set up to do. And so if you suppress the immune system, you have all sorts of bad effects. Increased numbers of colds, increased numbers of other infectious diseases, loss of hair, all the types of problems that occur with chemotherapeutic regimens. So even though there was some evidence that MS could be controlled a little bit with these treatments, they never caught on because the trade-off between benefit and toxicity was not a good trade-off. But they did give us further information that the use of these drugs being immunosuppressive, that there was something to it, to the way they worked. For many decades, we also knew that anti-inflammatory medications helped. And as I mentioned, the initial attack of MS is the T cells getting into the central nervous system and causing damage to the myelin, causing inflammation of the myelin, the coating of the nerve. Steroids, corticosteroids, are potent anti-inflammatory medications. And so early in the disease, they were used to treat MS, and chemicals that cause the body to put out more of its own steroid types of chemicals were used to treat MS. So for many decades, all we had to treat the disease were cytotoxic drugs and anti-inflammatory corticosteroid medications. And then there was the realization that there were viruses in the picture in some way. And so researchers tried antiviral medications. And in the 1970s or so, 60s, 70s, there was some indication that some antiviral medications may help the disease too. But again, they were not really potent medications. It was really not until the immunomodulating drugs came on the scene that we had good treatments for MS. I mentioned the first of the disease-modifying treatments was in 1993, and this was interferon beta 1b, or beta-seron, and this was a type of normal product of the human body, an interferon. Interferons are produced by the body to protect against viral attack. Indeed, part of the reasoning of trying an interferon to treat MS was the thought that there was a virus that was related to the attack of MS. Since 1993, there have been more of the interferons that have come on the market. Following beta-seron, which was interferon beta 1b, there was Avonex, which was given once a week in the muscle, interferon beta 1a, and then later came Rebif, which is interferon given under the skin 3 times a week. Glatiramer acetate, or Copaxone, came on the market and was approved by the FDA in the 1990s. And Copaxone is given under the skin once a day. It is not an interferon. It works by an entirely different mechanism, and it seems to, in a sense, desensitize the person to whatever the attack is that's causing the MS lesions to get activated. In 2000, a new chemotherapeutic drug, mitoxantrone, was FDA approved for use in MS. Its advantages were that it was very effective and toxicity was somewhat less. Much more recently, natalizumab, which is an anti-T cell monoclonal antibody, which is really a designer drug designed to block these T cells from getting into the central nervous system and causing inflammation of the myelin. That has been very effective in diseases that are caused by T cells, such as multiple sclerosis. I mentioned that the earliest drugs are really chemotoxic, the chemotherapeutic agents, but that as you increased their dose and you got better results of the control of the MS, but you also had more toxicity. So in the late 1990s, we and other people in the MS research area explored the use of stem cell transplants for treating MS. And the concept was the patient with MS would get complete and very intense immunosuppressive treatment. And that would then appear to really eliminate the attack of MS. But then to keep the patient alive, the stem cell transplants had to reconstitute their blood system. There's also interest in developing new compounds, new types of compounds, which currently are not on the market, but all of which work on the immune system to downregulate the attack on the brain and spinal cord. And then lastly, combinations of different medications can be used and sometimes will be better than any one medication itself. For example, a drug such as mitoxantrone, which is Novantrone, which is a chemotherapeutic type of agent, can be used with interferons to help give added protection to the person with MS. And there is currently a large clinical trial looking at a combination of glutaramine acetate with an interferon to see if that's better than either one alone. We don't yet have information on whether that's effective or not. As we see new drugs coming on the market, we also see new types of toxicity. And often toxicity does not show up for years until after a person has had a medication. So we're now entering into an era of new medications which are going to be more effective on MS, but also potentially more toxic. You've heard me previously talk about the importance of neuroplasticity to keep the central nervous system functioning in persons with MS. As the disease progresses, there is an inevitable toll it takes on the brain and spinal cord, and yet patients continue functioning. This is the beauty of the self-healing process of neuroplasticity. One of the earliest things that patients with MS notice is their difficulty of multitasking. Multitasking, which many people do increasingly in our society, become increasingly more difficult as MS takes its subtle but definite toll on the human brain. This is somewhat analogous to when an interstate freeway has a massive accident. There is no traffic going down that road. Persons have to get off the freeway, find side roads, get back on the freeway. Think of that happening in the brain of a person with MS. There's a lot of effort involved and a lot of lack of synchronization involved, which is why the multitasking is so difficult. We've talked about what causes MS, what MS does to the brain and spinal cord, ways in which the disease itself can be managed, likely ways in which it can present, and likely symptoms that it can cause. But what about the treatment of symptoms? I believe that this is frequently an overlooked component of the healthcare management of the person with MS. I mentioned that the first and most important and most common symptom appears to be fatigue. Other symptoms are weakness, spasticity, pain, depression, memory problems, cognitive problems, bladder problems, vision problems, tremor, heat intolerance, and issues with jobs and employment and wellness. You will hear about all of these symptoms in this series and later programs. But briefly, I want to tell you that there are treatments for all of these. Sometimes these treatments are not as good as we'd like, and they're not able to cure all of these, but yet we can hopefully make patients with these symptoms better. For example, fatigue. Fatigue, as I mentioned, may be related to the fact that there is the need to have the brain engaged in multitasking activities in a neuroplastic way, which is different than true multitasking. But there are medications that can help patients with fatigue. Weakness can be helped with bracing or exercises. There are really good medications that can treat spasticity. Pain can be managed through a variety of medication, psychologic, self-hypnosis, and other methods. Memory and cognitive problems can be very difficult and challenging to the patient who has them, but there are tricks or treatment strategies that can be used to help the patient. Bladder problems are common, as I mentioned, but there are some very good treatment mechanisms out there. Vision can be treated by rapidly giving the person who has an acute bout of optic neuritis corticosteroids to reduce inflammation. Treatments for tremor are difficult, but some are available. Heat intolerance can be treated with cooling jackets or heat extraction techniques. And it is most important to remember that somebody who has MS should not attribute all of her neurologic symptoms to MS. Patients with MS can still get carpal tunnel syndrome. They can still get a herniated disc causing a nerve root irritation down the leg. They can still get the kinds of other problems that anybody else can get causing neurologic symptoms. So it's important that the person with MS and the person with MS's physician recognize that sometimes symptoms that a person has may be due to something that is very treatable. MS is still a disease looking for better and safer treatments. This involves clinical trials. Clinical trials are drug trials, new drug trials for a disease that will recruit subjects with that disease who can try the new medication and see how well they do on it. In a sense, this is something that's very important for the field, but in another sense, with all of the good drugs we have now available to treat MS, one can make a good case that you might as well just stay with something that works well for you. I think there is the opportunity for everyone with MS, however, to participate in new solutions for treating this disease, and it's something that I would ask that you give consideration to. Also, I'd like to tell you where you could go for some further information. One is the website of our clinical center, the Western MS Center, and that is www.westernmscenter.org. The second is a book that researchers from our Research and Training Center have put together, the MS Workbook, Living Fully with Multiple Sclerosis. This is a book that is available at any bookseller. I want to thank you for watching this first in this series, and look to see you back in our next program. I will be back as host of the remaining programs in this series. I wish you all the best of luck. Until the next time.